Hello everyone, and welcome to today's webinar, Menorrhagia in the Adolescent. I'm Anne-Marie Nazaro, Executive Director of the Foundation for Women and Girls with Blood Disorders, and I have the privilege of thanking you for joining us today and for completing pre-test questions with your registration. This is very helpful to us as part of the metrics we need for our education work. We'd like to start with some housekeeping details, and the first will be described by our technical specialist, Mohammed Ahmed. Mohammed?
Thank you, Anne-Marie. You have joined the presentation listening using your computer speaker system by default. If you would prefer to join over the telephone, just select Use Telephone in the audio pane and the dial-in information will be displayed. You will also have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. Now back to you, Anne-Marie.
Thank you so much, Mohammed. Another essential housekeeping detail is to display for you the important information about our CME accreditation, and that this webinar was developed according to ACCME guidelines. Because this webinar is an abiding education program that will be archived on our website, fwgbd.org, for you and so that additional providers can take this course at any time, this syllabus that you're seeing now will also be displayed with the presentation. We're pleased that Menorrhagia in the Adolescent has been approved for 1 1/4 AMA Physicians Recognition Award Category 1 credits. The planning committee for today's presentation includes our Activity Medical Director, Dr. Evelyn Lockhart at Duke University School of Medicine, Dr. Andra James at the University of Virginia, Dr. Barb Kunkel from University of Washington, and Dr. Roshni Kulkarni, who's at Michigan State. Drs. James, Kunkel, and Kulkarni are 3 internationally recognized experts in women and girls' blood disorders. They, in fact, started our foundation to educate their peers, all providers, about blood disorders affecting women and girls. Dr. Lynetta Jordan, University of Miami, and our faculty today, Dr. Jennifer Dietrich, serve on our education committee, as you see here, and they also serve on our founding board of directors. As Dr. Dietrich is our faculty for today, I would like to tell you a little bit more about her. Dr. Dietrich is Associate Professor in the Department of Obstetrics and Gynecology and the Department of Pediatrics at Baylor College of Medicine. She's Division Director for Pediatric and Adolescent Gynecology and CME Director at Baylor. And Dr. Dietrich is Chief of Pediatric Adolescent Gynecology at Texas Children's Hospital. And now, I would like to talk briefly about our foundation. Those 3 top experts, those physician experts in women, girls, blood disorders, Drs. James, Kulkarni, and Kunkel, they became aware through their own practice and research that blood disorders had serious and sometimes life-threatening medical consequences for women across all life stages. They saw the need for a foundation to educate their peers across disciplines, healthcare providers who would manage and care for these women at various life stages. So as depicted here, educating pediatricians through geriatricians and all specialties in between is actually the focus of our foundation. Our founding board believes that by educating healthcare providers across disciplines, we will ensure that we can achieve our vision, that all women and adolescent girls with blood disorders are correctly diagnosed and optimally treated and managed at every life stage. You are joining us today for one of our foundation's core tactics for educating healthcare providers. To ensure that you receive the highest quality education, we want to show you that our faculty and planning committee, in accordance with Duke School of Medicine policy, have each disclosed any significant financial interests or other interests relative to the topic we will be discussing. These disclosures allow you to better evaluate the objectivity of the information presented in this lecture. And now I am delighted to present to you Dr. Jennifer Dietrich and Menorrhagia in the Adolescent.
Okay. Good afternoon, everyone. I hope everyone can hear me fairly well. I am glad that you've had a chance to join us today. And just to briefly review, the main goals of today's lecture will be to discuss challenging cases of blood disorders, discuss management strategies using hormonal and non-hormonal options, and discuss ways in which collaboration augments management. So to give you a little background, abnormal uterine bleeding is the most common complaint of adolescents reporting to gynecologists. And believe it or not, if we take menorrhagia as heavy menstrual periods, 40% of adolescents actually report having heavy periods. The most common presenting symptom in women with bleeding disorders happens to be menorrhagia. And in fact, 10 to 48% of adolescents, depending on the studies that you read, with menorrhagia have a bleeding disorder underlying. If we look at the worldwide context, it's important to kind of consider that this is not just a problem that we face in North America, but it's a problem that really affects women worldwide. And there are prevalence estimates that range among adolescents with menorrhagia of 5 to 36% with von Willebrand disease, 2 to 44% with platelet dysfunction, 8% with a clotting factor deficiency, and 13 to 20% with thrombocytopenia. It's also interesting to note that there is some change in culture to some degree. And menorrhagia and bleeding disorder education has come to the forefront. In this study, involving over 240 OB residency programs, a survey was conducted. And essentially, this looked at several different class years of OB residents from the first year to the fourth year. And the survey inquired about the knowledge and experience in managing problems among women or adolescents with menorrhagia and their proficiency in assessment and management of this condition. And so what the survey actually found is that, in fact, they reported, at least in the intern year, only 9 hours of training in the medical management of menorrhagia. It was around 11 hours, which is not significantly different from the intern year, during the second, third, and fourth years of OBGYN residency. In addition, 2/3 reported training in menorrhagia and bleeding disorders was sufficient, although less than 25% reported they would send tests for specific bleeding disorders despite certain clinical signs. And in addition, it was noted that among survey responses, they inconsistently asked appropriate questions regarding bleeding history. So certainly there is some improvement that we have an opportunity to make in our education of young trainees. And so definitely we are delighted to see that more training and more of these programs are being offered to faculty and to trainees. Well, we have to talk a little bit about diagnosis, and this is something that we can't reiterate enough. History is everything. How many times in medical school did we hear from our colleagues that history tells you 95% of what you need to know? Well, it is no different here. Certainly in an adolescent population, although we would like to think that these folks are not engaging in high-risk activities, unfortunately, we need to rule out pregnancy. It's something that we can't forget to ask about, and so it should be part of our historical information that we gather when a patient presents. And then finally, we need to do a really thorough examination. I'm showing here over on the side a couple of different ways and different tools that you can use to gauge history about the menstrual cycle from your adolescent. So we have a monthly menstrual calendar, and as we all know, there are ways to do this either in paper form or in electronic form nowadays. And then finally, we have a way to kind of gauge how many pads or tampons they may be using during a menstrual cycle. And this specific form happens to be a pictorial blood assessment chart, and is one way in which heavy menstrual cycles have been validated over time, such that each of these individual pads or tampons and clots or flooding occurring with a menstrual cycle over 4, 5, 6, 7, or 8 days are assigned a score. And the total of the score, if over 100, is validated and consistent for menorrhagia. So the PBAC score that I just briefly spoke about. So if we look at a pediatric and adolescent gynecology population, this study actually tried to gauge, well, how good are we at assessing the validity of this score in an adolescent population? Because many of the studies have been done in adult women. And so this study looked at several different groups of adolescents. Group 1 with heavy menses, Group 2 with normal menses, presumably not menorrhagia, and Group 3 light menses. And so what we found is that actually our groups were quite similar in terms of their age. There were no statistical differences in their age at menarche. However, what we found is that when we did a pictorial blood assessment chart, there were very different scores from Group 1 in the menorrhagia category, Group 2 in the normal menses category, and Group 3 in the light menses category. And this was statistically significant. And so let's review a bleeding history briefly. We want to know things about not only the gynecologic history, but we want to know other things about potential bleeding problems. So for instance, are they having nosebleeds that last greater than 10 minutes and require medical attention? Do they have bleeding from their gums, even while brushing their teeth or when going to the dentist for routine procedures? Unexplained bleeding from the gastrointestinal tract, bruising with minimal or no trauma, prolonged bleeding from wounds, heavy or prolonged or recurrent bleeding after surgery, difficulty with bleeding after dental procedures and tooth extraction. Have they had a history of anemia requiring iron therapy or transfusion, heavy menstrual bleeding, and finally a family history of bleeding or a bleeding disorder. So our family history is also quite important. And actually, if we look at whether or not the family history is positive or negative, family history is quite helpful in the situation where we might expect a condition such as von Willebrand disease. Part of this is because there is an autosomal inheritance pattern. And secondarily, in the case of hemophilia and hemophilia carriers, we know that it is an X-linked recessive trait, and therefore, if this is a condition in the family history, it's one that we should not cross off the list for even for an adolescent female. Nonetheless, a negative family history does not exclude a bleeding disorder. So for instance, even a type 1 von Willebrand disease patient may have incomplete penetrance, there may be variable expressivity, and as a result, there may be variable symptoms. Some women in the family may be symptomatic and others may not. Nonetheless, all family members may in fact have a mutation. Hemophilia. For instance, a father may have mild disease, and carriers, just as I mentioned previously, may be asymptomatic or symptomatic, and therefore the asymptomatic carrier may not be aware she has a condition. So let's go into detail about the menstrual history just briefly. So we can kind of break this up into two different categories of qualitative questions and quantitative questions. If someone has menstrual cycles lasting more than 7 days, that should raise an eyebrow. If they're changing a pad or tampon more than hourly, that should also raise an eyebrow. If they're passing clots greater than 1 inch in diameter, again, cause for concern, and then certainly soaking through clothes or bedding at night during their menstrual cycle. And then we have the quantitative measures that have specifically been correlated with menorrhagia, and those include greater than 80 cc's of blood loss or greater than 80 mLs of blood loss, and a PBAC score, just as I mentioned previously, of greater than 100. Now, I did briefly mention and allude to the fact that many of our adolescents are using electronic forms to record their cycle. And in fact, I think it can be a very good way for the adolescent to give you accurate information. Number one, I think that it engages them and they're more likely to actually participate. And most teens will have a phone or something close by, so it's easy for them to write things down. If they happen to, be able to write down things like how many pads or tampons they're using, they can share that information when they come back with us. And so it's a very useful tool, and many of our teens, in fact, use this. Well, so once we have gained our history, it is extremely important for us to consider not only a physical examination and outward signs of abnormal bruising or petechiae, but we also will likely proceed with a laboratory evaluation. And the initial evaluation typically includes a complete blood count, which is involving a hemoglobin, a hematocrit, and a platelet count, a prothrombin time, a partial thromboplastin time, a fibrinogen, and a von Willebrand assay. There are some special considerations, however, specifically for our von Willebrand disease panel. And one of the things we have to think about is that, as we take care of patients who are presenting to us with heavy menstrual cycles, it's really important to discuss with the family that during a heavy acute bleeding episode, repeat testing may be necessary and is often necessary. Part of this is because in a state of stress, illness, or inflammation, von Willebrand factor can increase. Interestingly, this is a good thing, but exercise can actually force the levels to be higher. Certain medications, hormonal therapies, estrogen, pregnancy, the factors may be increased with age, with hyperthyroid conditions, and of course in the acute bleeding phase. In addition, we have to think about the potential for von Willebrand factor to be altered because of other conditions, and that can include hypothyroidism. Finally, blood type also plays a role to some degree in von Willebrand factor levels, and blood group O is associated with lower von Willebrand factor. Some of the things we need to think about as we're managing all of these different components that can affect the factor, we need to think about our institution as well. Do we have on-site testing and immediate sample processing? And we have to think about will there be a delay in testing because it has to be transported somewhere? Do we have the ability to store our sample properly? As in a cold storage environment, low von Willebrand factor may be the case. We want to also remember to test sometime during the early days of the menstrual cycle. It is ideal to test during the first 3 days of the menstrual cycle. And certainly we know this because estrogen levels are typically lowest during these first few days of the menstrual cycle. And in correlation with this, the von Willebrand factor tends to be lowest during these first 3 days of the menstrual cycle. And finally, we need to be mindful of any other physiologic states resulting in stress that can affect the von Willebrand factor levels. In terms of platelet disorder evaluation, there are some things that we think about. We definitely want to know about the platelet number, which we can get very easily from our complete blood count, the platelet size, which includes an examination of the platelets under the microscope, and the platelet volume. We want to look at prior platelet counts if available, and if there's a concern, we want to work with our colleagues in hematology to coordinate testing for platelet aggregometry or flow cytometry or electron microscopy. If we are specifically concerned about clotting factor deficiencies, some of the things that we consider in the category of prolonged PT, we're looking at kind of the extrinsic pathway here. We want to think about possibly factor VII deficiency. In the intrinsic category, we can consider factors 8, 9, 11, or 12 deficiency with a prolonged PTT alone. In the situation where both PT and PTT are prolonged, you should think about factors 2, 5, or 10 and fibrinogen disorders. And then there are a number of different conditions that fall into the other category, and this includes factor 13 deficiency and other rare fibrinolytic pathway defects. So I thought it would be nice for us to go over a few cases, and this is case 1 that we'll discuss today. We have a 15-year-old hemodynamically stable female who presents to the ER with vaginal bleeding, which worsened over a 7-day period. She reported passing clots at home, but since her arrival in the ER, she reported that it seems to have slowed down. She reports menorrhagia at age 13 with regular cycles, and her last menstrual period was 2 weeks ago. She reports it lasted about 7 days. She also reports recent onset of sexual activity about 3 weeks prior. Additional history revealed that 3 weeks ago, when she attempted intercourse, something popped and just started bleeding. She was seen at an outside institution where she required some vaginal stitches repair. And every week since that repair, she's reported intermittent episodes of bleeding and has required 2 additional episodes of suturing since the initial repair. On exam, she has Tanner 5 breasts and genitalia. There is evidence of sutures present near the hymenal ring where she reported the tear, but there were no other tears and no evidence of menstrual bleeding. However, at the suture sites, there was some oozing. There were initial labs sent, and her urine pregnancy test was negative. A gonorrhea and chlamydia test were negative. Her hemoglobin and hematocrit were 7.1 and 21.3, respectively. Platelets were 160. And therefore, in light of her presentation, a von Willebrand panel was ordered. An aristocetin cofactor was noted to be 21. Her von Willebrand factor was noted to be 11, and a factor 8 level was 16. Subsequently, hematology was consulted, and a DDAVP stimulation test was ordered, and she was found to be non-responsive. Well, ultimately, in conjunction with our hematology colleagues, a diagnosis of von Willebrand disease, severe type 1, was made. And our treatment strategy really kind of addressed several things. And certainly we wanted to help address her heavy periods, her current bleeding episode, and provide something for contraception, knowing that she was a sexually active adolescent. And so our treatment plan involved oral contraceptive pills and tranexamic acid for breakthrough bleeding events. Well, unfortunately, sometimes it takes a few times for adolescents to get used to taking oral contraceptive pills, and so not surprisingly, our patient would intermittently forget to take combined oral contraceptives and her tranexamic acid for breakthrough bleeding. She subsequently presented to the ER with acute abdominal pain and a 5-centimeter hemorrhagic cyst that was noted on pelvic ultrasound. Treatment strategy at this point, knowing her lack of responsiveness to DDAVP, was intravenous factor complex replacement and tranexamic acid. The goal here was to stabilize the hemorrhagic cyst, prevent expansion of the cyst, and prevent a potential trip to the operating room, given her bleeding condition. And so our result, thankfully, was that her hemorrhagic cyst stabilized, we provided education, and her oral contraceptive pills were reinitiated. Eventually, her hemorrhagic cyst resolved without surgical intervention. And so long term, our patient was instructed that if she ran out of pills or forgot to take pills, and did not reinitiate her medication, she could have another hemorrhagic cyst. She was also instructed to take her tranexamic acid in this event and to notify a gynecologist and a hematologist immediately in case of a need for intravenous factor replacement, since she traveled from a long distance to get here. Well, in case 2, this is a little bit different, so we're shifting gears just a tiny bit. We have a younger female, an 11-year-old Asian female, who presented to the ER with heavy menstrual bleeding. Her mom reported to the ER physicians that her daughter's menstrual cycles had become progressively heavier, and this cycle, in fact, had lasted for 10 days. Past medical history was otherwise negative. Past surgical history was negative. Unfortunately, family history was not known as she was adopted, and her review of systems was negative for easy bruising, gingival bleeding, or epistaxis. On exam, she was found to be tachycardic with a pulse of 122. Her blood pressure was low at 88/50, and orthostasis was confirmed. She had normal pubertal development, no evidence of trauma, but active heavy menstrual bleeding was noted. Of note, on her skin exam, she had no evidence of bruising or petechial rashes. A pelvic ultrasound was normal, and her initial laboratory evaluation revealed a hemoglobin of 4.5, platelets of 110. Her initial coagulation studies were normal, and a von Willebrand panel was normal. Well, ultimately, this young lady required a transfusion, and she was given initially 2 units of packed RBCs. Additionally, due to her inability to tolerate oral contraceptive pills, intravenous hormones were initiated. However, intermittent episodes of heavy bleeding continued beyond 12 hours post-therapy, and her hemoglobin after 2 units was 5.5, so not an appropriate rise. Platelet function studies were sent, and unfortunately, at our institution, it takes about 3 days for these more specific studies to return. But nonetheless, she received the blood that she needed to help her with an appropriate rise. And then in addition, IV aminocaproic acid was initiated. Her bleeding definitely slowed, but did continue beyond 36 hours post-initiation of therapy. And her hemoglobin, although it's rising, is still not an appropriate rise. So once again, she received 2 additional units, and further laboratory evaluation resulted, revealing a rare platelet function defect and gray platelet syndrome. So ultimately, platelets were given and bleeding ceased within 12 hours, and she finally began to have an appropriate rise in her hemoglobin. She stabilized at that point. And so really, treatment strategy for her involved transitioning her from IV formulations to an oral formulation for acute and transition management of her heavy menstrual bleeding episode. Ultimately, we were able to switch this patient to an oral regimen utilizing an oral contraceptive taper and aminocaproic acid for 7 days with success. Long term, she was managed well with oral contraceptives alone and only very intermittent use of aminocaproic acid. So I hope these cases demonstrate that, really the critical thing in the adolescent is that, maintaining fertility is critical. These are young patients, and hysterectomy in this population is not an option. Hormones are really the first line of defense. If a bleeding disorder diagnosis is known, working with a hematologist from the very beginning is important for management of menorrhagia, since both hormones and hematologic agents may be necessary. Now, obviously, sometimes when bleeding continues beyond what we would expect, or we cannot, we don't see an appropriate rise in hemoglobin, or a patient becomes unstable, mechanical options to control bleeding might also be necessary. We do have the option for utilization of a Foley balloon, a 30 cc Foley balloon, that can be used to tamponade the uterus from the inside for 24 hours. This can then be easily removed afterwards. And then finally, a dilation and curettage, or D&C, really should be our last resort in this population, as we know that scarring can occur in young patients after a D&C. And finally, in a patient who potentially has a bleeding disorder, a D&C can actually result in more bleeding. So just to briefly review, if we have an adolescent presenting to the emergency room with acute menorrhagia, I think it's easy to kind of subcategorize these into a few different categories in terms of how severe the bleeding is and how severe the anemia is. So in the situation of mild menstrual bleeding, and we see a hemoglobin greater than 11, we might be able to provide reassurance, education, offer a low-dose oral contraceptive pill, and reevaluate. Certainly, if a patient does not respond to our therapy in a way that we feel would be appropriate, we should never hesitate to send a panel to rule out coagulopathy or a bleeding disorder. In the moderate category, education is certainly something we want to think about. In the adolescent population, we definitely want to rule out any kind of sexually transmitted infections, and we also want to begin to test for things like bleeding conditions. We can offer iron, low-dose oral contraceptive tapers, and reevaluate. In the severe and hypovolemic shock category, no question we want to rule out coagulopathy. In the severe category, we may still be able to offer iron, but might want to consider a high-dose oral contraceptive taper. And then we want to reevaluate these patients sooner. And then finally, in the case of severe anemia and hypovolemic shock, these patients are going to certainly be admitted for high-dose hormones, possibly in IV form, if they cannot tolerate oral route. And then finally, only intervene mechanically in extreme cases that are non-responsive to hormonal management. So once again, our roadmap. You have a patient presenting with acute menorrhagia. We are going to proceed with a laboratory evaluation, admit for hormonal treatment. We definitely do not want to forget to rule out pregnancy. We're going to get an ultrasound to rule out any problems that might be resulting in bleeding from an anatomic standpoint, such as a polyp. If the bleeding stops, we can easily taper with oral contraceptive pills. But if the bleeding continues, that's when we have to get more serious about different options. Well, just to briefly go over, how does estrogen work? Well, the mechanism of action here is really negative feedback inhibition of gonadotropins. We're going to suppress ovulation, and ultimately over time, it will result in thinning of the endometrial lining. We have to be mindful, however, that estrogen is not for every patient. So we need to make sure we've taken a good history to avoid use of this hormone in patients with serious cardiovascular concerns, renal or liver disease, uncontrolled hypertension, or a thrombophilia. So how do we use estrogens in the acute setting? Well, if we're using an IV form, obviously if a patient cannot take an oral form, we can use an IV conjugated estrogen, 25 milligrams every 6 hours until the bleeding stops. In the majority of cases, the bleeding will stop in 24 hours. Alternatively, if your adolescent patient is able to tolerate an oral regimen, a 50 microgram pill with ethinyl estradiol has approximately the same bioavailability as a conjugated estrogen administered in IV form. The pills should also be administered every 6 hours until the bleeding stops, and then these pills can be tapered off. One way in which to kind of standardize and make the process a little bit more efficient from the time that the patient presents to the ER to the time the patient might be admitted to the hospital is, standard order sets. Many institutions are transitioning to an electronic medical record, and we have the opportunity to develop order sets to kind of help expedite care for patients who are presenting in this severe fashion. So let's briefly talk about progesterone. So the mechanism of action is very similar in that it does provide some negative feedback inhibition, but progestin types some types do not fully halt ovulatory function. It does, however, similarly result in thinning of the endometrial lining. And really, different from estrogens, the main contraindication to a progestin hormone is an allergy in the past. So for progesterones, we have an opportunity in the patient who cannot take estrogens. They may have a contraindication. Progesterone options are available to help control bleeding in the acute setting. And so norethindrone acetate may be utilized 5 to 10 milligrams every 4 hours orally until the bleeding stops, and then this medication can be tapered. In addition, medroxyprogesterone may be administered orally 10 to 40 milligrams every 4 hours, and then it may be tapered. We've also had the experience with several of our patients who were ultimately diagnosed with bleeding disorders who just simply had poor response to pills or other methods. They really reported a lot of side effects related to nausea and emesis with certain pill types, and they declined taking pills or other methods further. And so they wanted to try something different, even if off-label, and therefore a creative taper was offered with the patch and the ring. And so in these patients who presented with symptomatic acute menorrhagia, they were given a patch and a ring at the same time for 7 days. After 7 days, the ring was removed and a combination patch that was placed during the first week, a new patch was placed for the next 7 days. After that 7-day period, that patch was removed and then the ring was replaced for 7 days. And then the patients could be transitioned to a long-term method at that point. Fortunately, we've had the experience to follow up with these patients, and we can see that every single one of these patients presenting with severe acute menorrhagia ultimately was diagnosed with either von Willebrand disease or a platelet function defect. None of these patients experienced breakthrough bleeding, and none of these patients experienced side effects. And we use this mnemonic at our institution, which stands for abdominal pain, chest pain, headaches, eye symptoms, or severe leg cramps, which might otherwise alert us to a reaction to the pill. Well, not everybody wants to be on a hormone either, and so we sometimes have the opportunity to use things like antifibrinolytics, just as I discussed in our cases previously. And the way that this works is that it really inhibits plasminogen. And so instead of fibrin being degraded, this antifibrinolytic agent works to block the transition from plasminogen to plasminogen-lysine bond. And therefore, it sort of helps prevent clot dissolution too early. We do have to be careful in certain populations nonetheless, among those with disseminated intravascular coagulation, thromboembolism, macroscopic hematuria, or color blindness. So one such antifibrinolytic is tranexamic acid, which is a synthetic derivative of the amino acid lysine, and it really exerts its effect through the reversible blockade of lysine binding sites on plasminogen, thereby preventing formation of plasmin, which works to degrade fibrin. Fortunately, we do have IV and PO forms, and the IV form works quicker. Dosing regimens that can be utilized and have been determined effective: 10 milligrams per kilogram IV every 8 hours, or 20 to 25 milligrams per kilogram orally every 8 hours. Just keep in mind that in some areas there has been noted a limited supply. There is no taper required of this medication, and the number of days to administer really will depend on the patient's clinical presentation. In addition, aminocaproic acid is another option. This is also a synthetic derivative and analog of the amino acid lysine, which inhibits enzymes such as plasmin, the enzyme responsible for fibrinolysis. Dosing regimens determined to be effective include 4 to 5 grams IV over 60 minutes, then taper to maintenance. Again, we want to stress that in some areas there may be a limited supply, so check with your institution and your pharmacy. And then finally, an oral regimen is available as well, typically dosed at 50 to 100 milligrams per kilogram, orally every 4 to 6 hours for 5 days. And there's some variation in this to some degree, and so it's a good idea to work with your hematologist since some patients have exceptions. So once again, just to take a break and reiterate, in the adolescent, maintaining fertility is critical, and hysterectomy in this population is not an option. Hormones are the first line of defense, and when the bleeding continues, mechanical options to control bleeding might be necessary, but we really want to proceed with these as a last resort. Here's an example of a 30 cc Foley balloon that can be used for balloon tamponade. This is what we would typically use for an adolescent, and an adolescent uterus is typically the exact size of a 30 cc Foley balloon. But essentially, based on your ultrasound results, you can determine how much you need to blow up the balloon in order to provide a tamponade effect. This is an example of a type of balloon with the same principle that is typically used for postpartum hemorrhage. But in the adolescent, we wouldn't be using a balloon quite this large. We would be using something a little smaller, gauged for their uterine size. So, second line options, once again. It is rarely indicated to do a DNC in an adolescent. Occasionally, it is, however, something that needs to be done if unresponsive to other options. An endometrial ablation or uterine artery embolization is really reserved for those women who have completed childbearing. And in addition, we want to reserve things like recombinant factor 7 as a last resort because it is really reserved for severe bleeding episodes for patients who have a known factor 7 deficiency. And we know that with this medication, it is an extreme procoagulant, so you need to be careful and work in conjunction with a hematologist. And finally, hysterectomy is extremely rarely indicated in an adolescent and is only as a last resort for a life-saving measure. Well, once we have controlled an acute bleeding episode, we have to think about maintenance. We have hormonal agents for maintenance, we have antifibrinolytic agents for maintenance, and we must take a team approach. We actually are fortunate at our institution to have a young women's bleeding disorder clinic at the Texas Children's Hospital, where we can see young adolescents who have transitioned from the acute bleeding phase to the maintenance phase, and we can make plans as a team to help manage their ongoing gynecologic problems or menstrual problems. And so when we're choosing different therapies, we have a lot of factors that we consider in the adolescent. And so some of the things that we think of are patient-specific and medication-specific. Well, in the patient-specific category, we think about compliance. Not every adolescent is really looking forward to taking a pill every single day. It may be difficult for them to remember. And so we also want their feedback and their information about the preference in therapy that they would like to use. Medical conditions will definitely impact our decision to choose one medication over another, and the emergent nature, obviously, acute or chronic. Finally, in the medication-specific category, we think of cost, availability at the pharmacy, prior medications attempted, and how do we want to augment current therapy if they are already on therapy. There are additional considerations that we want to think about in pubertal females with blood disorders. And so I list this here mostly for your reference, that really this paper addresses gynecologic concerns in pubertal females with blood disorders and provides a lot of opportunity for discussion about different options that can be utilized in patients with bleeding conditions that are due to blood dyscrasias or patients who have bleeding conditions as a result of requiring certain agents to thin the blood due to symptomatic thrombophilia. In the non-hormonal options category, we already know that in the hormonal options category we have plenty of options. We have pills, we have patches, we have rings, we have injections, we have IUDs. We have plenty of those things, and all of those can be utilized in the adolescent. But, you know, here in the United States, although antifibrinolytics have been utilized much longer in Europe and in Canada, we have not had them very long in the United States. And so in this study that looked at women without bleeding disorders, they were looking at the effectiveness of tranexamic acid versus various agents, either placebo or mefenamic acid, progestins, a variety of agents were utilized. And what they found is that regardless, tranexamic acid demonstrated a decrease in the mean blood loss for all patients, regardless of having an underlying bleeding disorder or not. So this really just looked at those without bleeding disorders. In the category of women with bleeding disorders, they demonstrated the same mean reduction, if not better, in fact. And in this category, they compared it to placebo, to desmopressin, and placebo. So again, this is good information for us to consider if we are transitioning a young woman from an acute controlled bleeding situation to a long-term maintenance therapy. Because again, not all women want to be on a hormone pill every day, or a patch or a ring. And then finally, additional things that we want to think about. And one of the reasons that we really enjoy having this combined clinic is that we want to plan in advance. And so if we have a patient with a bleeding condition, we want to plan in advance even for an IUD placement. Believe it or not, an IUD placement can result in some bleeding. Even placing a little stabilizing device on the cervix can result in a hematoma in somebody with a severe disorder. So you need to plan in advance with your hematologist to ensure proper pre-procedure medications are given. In addition, we have implants available that sometimes are appropriate for certain adolescents. And if you have an adolescent with a bleeding disorder, implant placement should only be planned after proper medications are given in conjunction with hematology recommendations. Certainly in this population, ovarian cysts are a possibility. It's a very, very common presenting complaint among many adolescent women. And so if we are going to plan a surgical procedure, such as an ovarian cystectomy, we want to work with our hematology colleagues, both preoperatively and postoperatively, to gauge the types of medications they will need to control their bleeding and prevent bleeding complications. So in summary today, menorrhagia is common among adolescents and may represent mild or even life-threatening bleeding conditions. So it's something we really need to kind of tune our ears to, you know, and really kind of make sure that we are asking all of the right questions in these adolescents, whether they're presenting acutely or with chronic heavy bleeding. Acute menorrhagia may be managed with a variety of hormonal options, but non-hormonal options are also useful in treating menorrhagia in this population. Acute severe menorrhagia may be the sign of an underlying bleeding disorder, and keep in mind that it's not uncommon that testing needs to be repeated. I'm happy to take any questions that have maybe been collected throughout the webinar, and I thank you for your attention today.
Thank you so much, Jen, Dr. Dietrich, for this thorough and excellent presentation. I will do a couple of things and then we will get to our questions. You were so thorough that we have, I think, 4 or 5 questions, and I'm very eager to get to them. Let me just say that for those of our participants who are interested in receiving continuing education credits, following this webinar, you will receive an email, and it will have post-test questions, of course, and a link to complete a Duke online evaluation form and obtain CMEs. Thank you. That is the slide that pertains. Please note, if you don't intend to receive credit or you don't need the credit for this webinar, we would very much still appreciate your taking a few minutes to complete evaluation questions. As I said earlier, they help with our metrics for the work we do in education. If we could have the next slide, I want to remind everyone that you can tell colleagues and friends that today's webinar will be archived and accessed on fwgbd.org, and everyone who's participating today will receive announcements for our next webinars and education events. Additionally, the Foundation has developed and will convene a Friday satellite symposium at the American Society of Hematology meeting in New Orleans in December. This symposium is another opportunity to hear, as you did today, a fabulous expert, another bunch of fabulous experts who will use another interactive format, live format, as they discuss blood disorders in women and girls across the lifespan, starting with adolescence and going right through menopause. Please visit our Foundation website and you'll get further details on this symposium, and you will be able to register. The registration is live now. And now we can do our questions, and I will start with Jen. Dr. Dietrich, you're ready?
Yes, I'm ready.
Good. So our first question, what is the role of IUDs in the management of chronic heavy refractory menstrual bleeding?
Okay, so I mean, that's a great question. So definitely, there are several different IUDs to keep in mind. And so there is a copper IUD and a progestin IUD. And certainly in the patient with a bleeding condition in whom you're trying to control bleeding episodes, the progestin IUD is the one that you would choose. Copper IUDs can typically result in more bleeding for some women. And so the progestin IUD is the best choice. Will provide not only over time a decrease in menstrual blood loss, a rise in the hemoglobin and hematocrit, a rise in the iron levels, and there have been several studies that address this in adult women and even in adolescents. But, once again, if you have a patient with a known bleeding condition, it may be more appropriate to place the IUD in a controlled situation in the operating room. And so again, something that you want to kind of plan in advance and talk over with your hematologist if you are going to plan placement in an adolescent with a bleeding disorder.
Our next question, could you please explain the contraindication of color blindness and antifibrinolytics? Excuse me.
Yeah, so this is an interesting one. In fact, it's one of the warning signs listed on the label. But this happens to be one of those medications that is still listed as a procoagulant, even though this is one that, as we review the mechanism, is meant to just kind of slow clot dissolution. And so, again, it may have something to do with the vascularity in certain patients who have color blindness. However, in addition, one thing to keep in mind is that, at too high of a dose, if you don't follow the dosing recommendations, there have been reports of patients who get color blindness if they've been exposed to high levels of antifibrinolytics. So once again, it may just go back to the vascularity in the eye for some patients.
So here I will give attribution because this starts out with fabulous talk, Jen, and that's from Sarah O'Brien. How do you approach the combined use of OCPs and antifibrinolytics in teenagers? Given that in certain ads for these products, there's a strong warning to not use both in combination. Are there any patients for whom you would not use both in combination?
Yeah, so I mean, I think that, once again, there are certain patients that just have such a severe bleeding condition that they are, we're always kind of constantly dealing with Virchow's triad, right? Remember that from medical school, where it's a careful balance between the bleeding and clotting factors. And so, there are some patients that are just so far over on the bleeding category that they really need some extra help in order to kind of cease their bleeding episode. And so we have had experience in using combined oral contraceptive pills, patches, or rings in conjunction with an antifibrinolytic in the situation where an adolescent is simply unresponsive to one therapy alone. The reverse situation has happened at our institution where they have tried intermittent use of antifibrinolytics, and while it may have made some difference, we kind of follow with their menstrual calendar and PBAC score, and when they're still significantly outside the range of what we would say is under control, we would add the second therapy. And so we have, definitely counseled very carefully every patient in whom we've used both of them together, to once again let us know if there are any concerns with headaches, visual changes, chest pain, leg cramps, or the like. And so we definitely counsel them very extensively about the clotting risk.
This is a corollary to an earlier question. What is your preferred method of menstrual bleeding suppression in adolescent girls with an inherited clotting disorder on anticoagulation, as injectable progestins seem to be thrombogenic?
I think that, we still have a lot of information about progestins that suggests that for many patients, the relative risk of thrombosis in many patients is 1, okay? And so for many patients, if we plan to use a progesterone method to control their menstrual bleeding, we do talk about that, but very frequently, once given all of the choices of progestins, many patients will choose the injection over, for instance, if they are sexually active, becoming pregnant. I mean, the one thing that we have to balance to some degree is that in a sexually active population, some adolescents are weighing the risk of pregnancy and severe thrombogenic condition in this situation versus progesterone and prevention of pregnancy, with possibly in the severe thrombophilic patient a slightly increased risk. But much of our data in the OB-GYN literature does suggest that the relative risk is 1, and certainly this would not be a population in which we would use the combined oral contraceptive method. In addition, we do counsel these patients that, if their bleeding is not as responsive, we tend to kind of counsel them about the progesterone IUD, because again, they're going to have the least amount of systemic side effect, and so a lot of our patients do choose this ultimately.
If Novo-7 was used, would you use closer to the factor 7 deficiency dosing, 15 to 45 micrograms per kilogram, or inhibitor dosing, 90 to 120 per kilogram, or something in between?
This is definitely one that I would work in conjunction with my hematology colleague to utilize, but, if it was the first time that a patient had really required something like factor 7, I would err on the side of using kind of the deficiency dosing.
Okay, and this one is asking if you should be discussing whether the condition is autosomal dominant or recessive. This is in von Willebrand disease.
Absolutely. It's definitely a discussion that we have, and if we do have an adolescent in whom we make a bleeding disorder diagnosis, absolutely, we talk to family members in conjunction with our hematology colleagues, and frequently family members are then tested. it's important to counsel these women as well, because certainly going forward, while we are going to help manage them during their adolescent years, ultimately they're going to go off to college, they're going to go see adult gynecologists, and one day maybe starting their own families, and so they need to know that there is a potential risk to pass that off to their offspring.
This one refers to a notation on the slides that talked about possible shortages of tranexamic acid and aminocaproic acid in some regions. And this questioner from the Idaho area is asking, if I were to experience such a shortage in supply, do you have any suggestions or recommendations for access?
It cut out there. Can you repeat that question one more time?
Yes. If I were to experience a shortage in the supply of tranexamic acid, is what was used here, do you have any suggestions for access?
Well, you know, obviously, fortunately, now we have the opportunity to use, we still probably have the opportunity to use aminocaproic acid. And so if tranexamic acid were unavailable, aminocaproic acid would be a fine option. And then certainly, you know, hormonal options are really the first line. And so if for some reason a patient had tried the antifibrinolytic first, you know, maybe that patient could then be counseled about attempting a hormone instead, especially in the situation of short supply.
Good. Well, that concludes our question and answer period. Jen, thank you so much, Dr. Dietrich. And we thank our participants and the questioners among our participants. You'll be able to review this webinar and share the proceedings, as we mentioned, at fwgbd.org. And on behalf of our Foundation for Women and Girls with Blood Disorders, the last slide, please, Jen. I think there's one more to go, which just thanks everyone. Great. Okay. On behalf of our entire board, our staff, we want to thank you for your participation, and we certainly look forward to your return to future Foundation for Women and Girls with Blood Disorders education events. Have a good rest of the day, everyone.